Okay, I take this opportunity to thank you all, ladies and gentlemen, for your attention. Now, since we finished these three presentations, I would like to now invite the other speakers, George and Andre, to join me in the panel to answer any questions that the audience may have. Christine is one of my consultant colleagues at the Chinese University of Hong Kong, Prince of Wales Hospital. She's our moderator today. She will moderate the questions, if there are any questions.
Yes,
Christine, are there any questions?
Yes, and I think Dr. Feigl has kindly answered some of them already, but I think the other panelists probably can also give us some thoughts on these questions. So the first question is from Dr. Muthukumar Rajagopalan. So his question is there a chance of nerve injury in an attempt to inject LA into the circumneural sheath?
Andre, there's a question to you.
You know, the whole question of intraneural injection has changed probably in the last 3 years. And yeah, intraneural, I am not sure what is meant by intraneural. We used to think that was into a fascicle. We now know you cannot inject into a fascicle. It's pretty impossible. Then we thought it was deep to the epineurium, and that gives you a great block, and it gives you an immediate block, and we try to avoid that. But deep to the circumneurium, if you look at the femoral nerve, for instance, it's not one nerve, it's 8 nerves, and they are all surrounded by this circumneurium. And if you now put your needle or catheter deep to that circumneurium, you are intraneural by definition, because the circumneurium is what it says, it's around the nerve. So I don't know what the word intraneural means, but what I do know is that intraneural injections, if you define that as out inside the circumneurium, there's no danger of nerve injury. If you inject it deep to the epineurium, your needle itself can actually damage the fascicles, and that is where the nerve injury comes from. It does not come from, or it can also come from a space-occupying thing that causes pressure and ischemia to that nerve. So I think the answer to that is it depends on your definition of an intraneural injection. But for me, an intraneural injection is deep to the circumneurium, which is an ideal place to put an injection. And, you know, while I have the floor, so to speak, may I just say thank you, Manoj, for that brilliant presentation. And I'm so glad to see that we all three actually agree 100% on everything we said. I was afraid that you're going to stick to the term paraneurium. Thank you for not doing that. And I was also afraid that you're going to say it's a nonsense concept, which is going to make us all pretty sad. But I thank you for that. And I must absolutely pay tribute. My talk is 100% Miguel Reyna's talk. He has to be accredited for all this work. My life changed when I picked up this book in 2017. That changed my life immediately, because we were always successful with catheters. And the reason we were successful with catheters, I never understood until I hold of this book. And now I know what happened there is that we placed, before ultrasound, in the good old days, you know, when you and I were still young, we placed catheters, and these catheters always worked. They didn't have secondary failure rates. And the reason for that, that's before ultrasound. We placed a nerve stimulator on the tip of this catheter, and the catheter goes exactly where the local anesthetic goes. So if you subcircumneural, the catheter will stay subcircumneural, and that twitches, that whatever twitch it is, that is where your block's going to be. But if your twitches disappear, you go intramuscular or to some other weird and wonderful place. And that's why we used to be successful. Then came ultrasound, and we became very unsuccessful with continuous nerve blocks. And the reason for that is we've just mentioned them. We were outside that fascial sheath called the circumnarium. Anyway, thank you. So if your definition is inside the circumnarium, then absolutely there's no danger of nerve injury. Inside the epineurum, you can damage the fascicles with your needles. Certainly, if you into a fascicle, you've achieved something that we could never achieve, and that's to inject intraneural.
Allow me to add a few words to Dr. Rajagopal's question. I think before we muster up a controversy here with our fraternity of regional anesthesia, I think let's keep it that the skin of the nerve is, take it as the epineurum. Although the circumneurum surrounds it, I think from a so-called danger point of view, it's the boundary would be the outer layer, which is the epineurum. In fact, the circumneurum is also an integral part of all nerves in the body. Now, while placing a needle deep to the epineurum is not desirable, not recommended, you may not find, even if you did, you may find that it may not always lead to a nerve injury, as is often mentioned. That does not mean that I'm condoning you to do so. Just remember that you must, as long as you can define that it and avert injecting large volume, then maybe you can avert long-term damage. That is again very speculative. However, now that our sweet spot of the nerve, and this is Dr. Bozart's words again, if the sweet spot of the nerve were to be the deep to the circumnurium and outside the epineurum, and that's where we are injecting most of our blocks today. Somehow inherently subcircumneural, like I showed you, the costoclavicular space. Now, what I have found in most cases is now we are getting closer and closer and closer to the nerve. Patients will report a lot of paresthesia, often with the sciatic nerve blocks, and I will discuss more about this in the later session. About 60% of patients will often report paresthesia when you do these subfascial injections. Now, they don't usually lead to long-term consequences, but some odd patients may develop paresthesia, which sometimes they report even after 1 month or even later. Now, the exact reason for this is not known. And if you go by Dr. Barrington's data, it's often the surgeon to blame. It's often a surgical reason for this long-term neurological deficit. But we still don't know a lot about the long-term effects of subparaneural injections, let's put it this way, in a very academic sense. Josh, do you have any comments?
Yes, I think I can pretty much agree with you both, because I think we talk about the same structures almost, and it's really depending on the definition and the terms we use. And that's causing some confusions because with all these different terms, I think we should sit together to a table to define new terms or any other to get one term for everything, what is used then all over the world. Anyway, I learned also today a lot about this circumneural sheath. And I pretty wonder where this is coming from. So this is something which is very important. Is it also a continuation or connection in between, for example, prevertebral fascia and epineurum or not? So this will be this is something for me which I want to investigate in the future time with some cross sections. And the second is that we have now this high resolution ultrasound images, as you showed it, Manoj. It was absolutely fascinating, and I think we have, we as anatomists have to go back to the labs and to take a look. What do we see in our ultrasound images? Because there is so much new visible now, and we have no idea yet. So this will
You're
be
right, George.
that's so thrilling. I really look forward for the next 2 years or 3 years.
Yes, George, I
Can-
think that's very true because what ultrasound and high definition ultrasound is showing us is what macroanatomy did not show us.
That's it.
Either
That's it.
either the preparation process or when somebody is deceased, the structures degrade or they decompose at an early stage. But in vivo images in the living individuals, they are indeed there, and we have illustrated that. So I think this high definition ultrasonography is actually contributing to improving our understanding of the microanatomy at a microanatomic level.
Even more, you're absolutely right. I think the structure has been always there, but we have never looked at it. And now, as the clinicians find something, I say, come on, there is no spread to, for example, the medial cord, which was called the corner pocket. Well, why? Because of the septum in between. Okay, we have never took a look on that because it was, okay, no reason for that to find it or to search for it. And this is something
I will
which
remember
is
that one, George. Zuckerberg Thalander ligament. Okay, the suspensory ligament.
Zuckerkandel sabilo.
Zuckerkandel sabilo ligament. Everyone, ladies and gentlemen, that is the word you must remember from today. Zuckerkandel sabilo ligament, and there are 4 of them. Okay,
6.
Christine, do we have? Christine, do we have any more?
Yeah, we have a couple of questions concerning costal clavicular blocks. I think a few of the attendees are particularly interested in putting in catheters. And because you've explained there is an anterior and also posterior compartment, and there is a septum in between. So a lot of attendees are interested in where exactly to put the catheter.
We will discuss more about this in a session dedicated to costoclavicular block, which is coming up in 2 weeks' time. But since you've asked the question, I'm happy to provide you some insight, but I can't give you any images. Now, because you see here, the nerves, the cords of the brachial plexus are very close to each other. Our original description was to place the needle at the center of the nerve cluster, if you may. So between the 3 cords. So we used to come from we come from a lateral to medial direction, placing the needle through the gap between the lateral and the posterior cord, directing it towards the medial cord. So that brought the needle at the center of this cord cluster. And we deposited a single large bolus of local anesthetic that produced the primary block. Now, I, for one, when I place catheters, I use catheter over needle in most circumstances now because I usually advance the needle tip to the point where I want to inject. And once I have distended, hydrodistended or distended that space with the local anesthetic, I usually don't advance the catheter anymore, and I just remove the needle or the stylet, if you may, and then attach it to the extension system that you're going to infuse the drug. So I usually still place it at the center. Now, whether this brings it to the posterior compartment or the anterior compartment, I haven't got no idea because we haven't investigated on that. But however, when we look at patients in the postoperative period where they're receiving a much lower concentration and a lower volume of local anesthetic than your primary dose of the local anesthetic, we still find that fairly low concentrations or low volumes, we need something like 4 or 5 mils of local anesthetic. I mean, there haven't been times in my clinical practice when I have seen such low concentrations being able to be delivered to produce comfort. When I say comfort, it means the patients are comfortable with not only the block, but today we are also giving them a lot of multimodal analgesics in conjunction with this. So to answer your question, I think the center of the cluster would be a good starting point. It would be a good safe point. I could not recommend at this stage that you put it anterior, posterior. Now, these septum are are existent, but to what extent they really impede the diffusion and the passage of the drugs from one compartment to another, it needs a lot of dedicated research to really answer those questions. But my gut feeling is, to give a large enough volume, then I think it can overcome all this. With time, the drugs, as the fixed principle says, it will diffuse over time and it will get to the sweet spot of that nerve. I hope that answers your question.
Okay. Thank you, Professor Carmichael. So there is another question concerning costal clavicular block. Probably will be covered in the next week as well. So it's from Dr. Tony Ng. So for costal clavicular brachial plexus block, so for those with small body build and relatively more curved clavicle, it's very difficult to visualize all the 3 chords at time. So is it a limitation for this block, or is there any tricks to advise?
I think to answer your question, Tony, is there is never a yes for everything. There are always difficult times when you do this. But my advice to you is when you do these costoclavicular block is to get the arm abducted as far as is comfortable for the patient. Now, there are 2 things. It elevates the clavicle to a certain extent and allows you more space to place the transducer, because very soon you will find that the coracoid process comes in the way of your transducer as well as the needle insertion. So once you elevate it, it kind of takes it outward and upwards and gives you more space for transducer placement and needle placement. So whether you are able to see 3 chords in most cases, I think I would say in majority of individuals, you are able to delineate all the 3 chords in that nerve cluster. My advice to you is, if you're not familiar with the costoclavicular brachial plexus block, is to start off using nerve stimulation. This is a very good example of learning anatomy, physiology, everything together, because when you guide your needle and ensure that you're using dextrose 5% instead of normal saline, for the reasons for which you're very familiar with, when you advance the needle and you approach the lateral cord or say the posterior cord, you immediately get a response that is consistent with stimulating that particular cord of the brachial plexus. And with time, you become very familiar with which one of these elements is which anatomical structure or which nerve. After a while, you don't need the nerve stimulator as such. So yes, you can identify all 3 chords in majority, and in some they are so tightly packed that I often say, okay, this is not maybe a good case to do this. We can move on to another location. Because if you try and hydrodissect your way into the center of the cluster when they're very compact, I think the chances of needle nerve contact is proportionately increased, which may not be desirable. Okay.
May I just add that exactly the same argument that you now present for starting continuous nerve blocks, you should also do exactly the same with the catheters. In other words, start off with ultrasound and then put a nerve stimulator on the catheter until you get very familiar with that, and then you can later on drop the nerve stimulator. But you have to learn that first, and that's certainly my way of teaching these. I start with everything I have and then take the other stuff away as we become more familiar.
Yeah, I think what you say, Andre, is a words of wisdom, and I get respect for that. But I think the audience would also appreciate that the ultrasound does not supplant the nerve stimulator. But when you marry them together, you have a winning combination, not only for clinical efficacy, but also for learning and teaching. If you have young doctors in your vicinity who are watching you doing it, or you're teaching them, I think using them in conjunction should be our way to go. We're not trying to prove to anybody that this is better than the other. But when used in conjunction, you have 2 different modalities that gives you 2 different information. One is giving you anatomical information. The other one is giving you physiological responses, anatomical responses that you become very familiar with time. Okay, Thank you, Christine, for moderating this and getting hold of the questions that you did. I like to take this opportunity to thank you, George and Andre. You've been great teachers in this field. And today I was so excited for the last few days that we would all be three together to present. And I think we did a bloody good job. So if you are an audience listening, you will not find a session like this anywhere, I tell you. So if you have a friend who hasn't visited this webinar today, ask them to register. They will get a link which they can later on watch. And this will definitely help you in your clinical practice. Thank you again, both of you. You've been great champions, and keep on staying safe and well. Don't go away. You don't have to go away, but we have another session. So all of you, I'd like to take a short break, give you all a short break. Go and pick up your favorite beverage and be back in 15 minutes time from now. Thank you.
Thank you.